Dr. Richard Baverstock has been practicing urology in Calgary since 2004, having completed urology residence training at the University of British Columbia in 2003 and a fellowship in reconstructive surgery, andrology, incontinence, and urodynamics in 2004 with Dr. Sender Hirschhorn at the University of Toronto. Since his return to Calgary, Dr. Baverstock has led the care of males with urethral stricture disease requiring reconstruction. He has also introduced a new technique in the management of male incontinence. He serves as the Director of Quality Assurance for the Division of Urology and recently finished a 3-year term as an elected representative to the Alberta Medical Association. Dr. Baverstock is the co-founder and director of VISIA. Is that how you say it? VISIA? Alberta, the Alberta Bladder Centre. This new clinic is a multidisciplinary clinic for the treatment of men and women with incontinence and lower urinary tract disorders. VISIA offers patients the full range of conservative and surgical options for their incontinence and pelvic floor disorders, such as tension-free vaginal tapes, prolapse repair, botulinum toxin injections for OAB, and male incontinence procedures. So, without any further hesitation, I'd like to bring Dr. Richard Baverstock to the front here. And I think we're...
Okay. Thank you guys very much for having me. I think this is actually my 3rd or 4th time. Bob, you probably remember.
At least 3 times.
At least 3 times coming here. And I will say, as I look around the room and see people that I recognize, as I'm thinking in my mind, oh my God, did I make him better or worse? So, and I don't claim to cure everything. Is that echoey?
It just doesn't seem very loud. Can you hear it?
A little bit more volume? Can you guys hear that okay? It's really loud for me. Maybe I'll move over here. How about that? Everybody okay? Okay. So I think it was Karen actually who originally invited me back in January. And in January it seemed like a great idea to be coming here on May 10th. But on one of the nicest nights of the year so far, when I had a babysitter and I was coming here, I was thinking that was funny of me to say that I'd come here tonight. So I'm going to give you guys just an update on male incontinence. Some of this, if you've seen one of these presentations before, some things aren't that new. Some things might be new to you. And whenever I talk about male incontinence, and female incontinence for that matter, it's important that we look at more than just stress incontinence. A lot of men that have prostatectomies get stress incontinence. Because I'm a little bit shameless, I'm also going to talk about VISIA. This is actually exciting, and it's exciting because one thing about being a urologist in Calgary, we're pretty humbled by the $26 million gift that we were given, the Southern Alberta Urology Institute. It's not very often in your career that somebody says, here's a fantastic building and resource center that you guys can work in. And we took advantage of that, Dr. Carlson and I, by setting up a component within the institute called the Alberta Bladder Center, where we're treating incontinence in men and women, and we take care of spinal cord patients as well. This, if you haven't been down to Rocky View lately, there's a parkade out front, and on top of that very frustrating parkade, there is a clinic, and up on top of the clinic there is where our bladder center is. We're actually the first door. So if you're going down the hallway looking for Dr. Metcalf and you've stopped in, you've actually probably stopped in to ask where his office is, because we're the first door, and then you're going to keep going down the hallway. So when I put together VISIA with Dr. Carlson, because we treat men and women, we put together a team of urologists. We brought in a urogynecologist, not for the men, but for women. We brought in a couple of family doctors, because other than work more, we couldn't clone ourselves. And a lot of the conditions that we see actually can be treated by family physicians. Not usually the men with incontinence after prostate therapy. So most men won't meet our family doctors. Most men will meet either Dr. Carlson or myself. We brought in a physiotherapist, and many of you may have worked with Yolanda at one of our other centers, and she's going to be working with us on Tuesdays, Thursdays, and Fridays. She fills an important role in having a center, somebody that can train people on their pelvic floor. We also have a nurse who we've hired that works in our center. So some people that are coming for injections for erections, for example, they may meet Nicole on their first visit, and then some of the support staff that we have. So we're actually a pretty big team. It's funny when you put together a big team and people are looking at you, all of a sudden you say, goodness, I got to work hard because I got a lot of salaries here to pay. when we put together this center, we wanted to cover everything because we take care of a lot of patients with spinal cord injury. We take care of a lot of female patients with multiple sclerosis. Then we see the male patients, we see female patients. A lot of what we do is just overactive bladder, which we're going to come to tonight. I have a specialty in reconstructive surgery. That's urethras and penile prostheses. There's female pelvic reconstruction, fistulas, and then another time I was here talking about the green light laser. Most urologists in Calgary do the green light laser. It's just something that we offer at our center. And if you spent any time in my office, nowadays you'll see running loops of information called MD Conversation. You'll usually, if you come see me, you usually get some type of handout, which you may or may never look at. But we've tried to just say, we tried to do something more than just have patients come in and then they go home and their wife says, "What did he say?" And he said, "Not much." And then I always tell men, bring your wife in, because if you go home and she says, "What did he say?" and you say, "Not much," you didn't realize that I was talking the whole time, and I gave you a handout, and we invited you to the website. So what we have with our education, we have MD Conversation at our site. We have a lot of handouts that we use. Even if it's talking about an artificial sphincter, you'll leave with a handout about it. Questionnaires, we have our nurse we can bring you back to sit down with now. I'm doing community health talks like tonight. Mentorships, we bring in family doctors that come and work with us. And then in the future, we're developing our website, a fellowship and training, and then we bring in a lot of residents. We don't have a urology residency, but we have other residents that come and work with us. This is the landing page of our website, vesia.ca. The Bladder Center offers a lot more than just men. It also offers treatment for women, so you'll see that. Women don't have prostates to start with, because it's really just a male sex organ. So it's really just an organ to actually give support to the sperm when they go on their way to meet the egg. And PSA is just a natural enzyme that all men have, and its job is actually to make ejaculation or semen go from sticky to liquid within about 5 minutes when it's outside the body. But PSA in minute levels is always released into the bloodstream, and it's released in the bloodstream with a large size of prostate cancer, infection, or inflammation. And that's what we use, the PSA, the family history, and the rectal exam to decide, are we worried, should we do a biopsy, etc.
So but you're probably got a power supply problem, so he's going to try and fix it.
Oh, no worries. No worries. Well, I can freelance too.
Go ahead.
I can even, I'll get freelance. It'll be the best ever. It'll be the, and they even brought show and tell too. So, actually, you're right, because I was going to start with anatomy anyway. I was going to tell you about why do men leak after prostate surgery, prostate therapy, cryo, brachytherapy, radiation. Because men leak for different reasons after prostate therapy. But the radical prostatectomy, which many men in this room probably have had, is probably the one that's best known for coughing, sneezing, running, jumping leakage, right? That's called stress incontinence. And why is that? Well, it's because every man in this room with a prostate has two valves. He's got a bladder neck, and as I sit here right now, or stand here, my bladder neck is actually closed. It's an absolute wall. Below my prostate is my external sphincter, and that's the one that I can control. So all day I've been waiting for Sears. They promised they'd call between 9 and 4. It's 3:59, I've been holding my pee all day, and I finally decide to go to the bathroom, and in the middle of peeing, the phone rings. And you can't, what can you do? So you gotta stop your pee because you don't want to miss the call. And that sphincter that you can grab, that's your external sphincter. So there's an internal valve that you can't control, called the bladder neck, and there's an external valve called the sphincter, which we can all control. And that's the one that you can tighten. Now, my own theory is that Mother Nature, when we were being formed, she gave every man in this room control based on their bladder neck, which they can't control. It's involuntary. It just is a natural, strong valve, and your external sphincter. And depending on how much of each one you got, if you remove the prostate and your external sphincter isn't very strong, you're that guy, and it's not a large number, maybe 10% of guys after prostatectomy that long-term have leakage that are bothered. And that's called stress incontinence. So just like a woman that's had children, coughing, sneezing, running, jumping, same with the man. Bends over to pick up a golf ball, and he's got leakage, coughing, sneezing, running, jumping. We see that. Most men will say, yeah, doc, after my prostate surgery and my catheter was removed, I couldn't control it. And actually, as a surgeon, I hate to call the guy a week or two after his catheter's out and say, how you doing? Because he's going to tell me, wow, this is horrible. And I'll just say, hang in there, hang in there, hang in there. Because for most men, not every man, otherwise I wouldn't have any work to do, but most men, the first couple of weeks after the prostate surgery and the first couple of weeks after the prostate catheter is out, you're going to have some leakage. It gets better in the nighttime, then it gets better at rest, and then it gets better with light activity, and then it gets better with heavy activity. But there's a percentage of men that have persistent coughing, sneezing, running, jumping leakage. For some guys it's mild, and they say, I can wear a pad, you know, it's not the end of the world. For other guys, it's very bothersome to wear a pad, and even for more guys, it's more than a pad. It's a diaper, or it's a condom catheter, or it's the dribble stop, which some people in this room may have seen. And so they want to do something more to manage their incontinence. That's usually when they'll end up seeing me, because there's two surgical managements that we'll do for coughing, sneezing, running, jumping leakage. For the mild leakage, there's something called a male sling. And the male sling is very much like what we've been doing with ladies. It's basically just a pelvic floor support. And I've got one sitting here. It's just a mesh. I'll pass it around the room so you guys can have a look. And this is called the Advance Male Sling. And it's designed just to support the urethra. But it's important. It's only for guys that are 1, 2, 3 pads per day. Beyond that, and if they're 3 heavy pads, I'm going to push you towards an artificial sphincter. So this is called the male sling, the Advanced Male Sling. And even when I first came here years ago, there was another version of this called the Invance. It was a bone anchor system. And the bone anchors, they loosened, it didn't seem to stay, and so for the most part the Invance has gone away, the Advance has come on. And this is the sling, and actually I'll pass it around, you guys can just have a look at it. It's very much the same polypropylene mesh, it's just like fishing line if you've ever gone fishing. And it's not absorbed, and it just stays in the body, and I'll show you if we get this going where it sits to support the urethra. If you're that guy that's more than that, really wet, then I'll talk to you about an artificial sphincter. Now, obviously there's a downside. Just as there's a downside to prostatectomy, there's a downside to cryotherapy, there's a downside to radiation, we can have a downside to any of these procedures. And what is the downside? It's usually that it either doesn't work or you get a complication related to the device, the sphincter. Perfect, my friend. I can even jump ahead because now we missed it. So we could have all run outside too and gotten cool. That would have been a good idea, actually. I'll just get right into here. I'm impressed you guys stay so late too. So here's my goal tonight again, is to understand why men have leakage, and then also how can it be treated? What can we do about it? So actually I made up this slide back in 2004, and I think it actually relates very well into my practice. A man walks into your office with prostate cancer. So you said, sure, your biopsy's positive and I think we'll need to do something about it. After surgery, rah, it looks good, looks like we cured you of it. And then the day the man realizes he doesn't have any erections, the day he realizes that doc said I was going to be dry by now, but now I'm not. And here, another high, the day that Viagra works for him, if Viagra does work for him. So there's a series, and obviously this man said in 2000 he was diagnosed. Here he is, 11 years later, talking at a prostate cancer support group. So this is a long roller coaster for a lot of people, highs and lows. And as a urologist that practices in prostate cancer, you see these highs and lows. What is my PSA? I got an erection. I didn't get an erection. I haven't dried up. When am I going to get better? And there's lots of that. So I said I'd go in. I always tell people that urology, what I do is very simple. The bladder is a pump and the urethra is a tube. And there's the prostate. And women have a very short urethra and they don't have a prostate surrounding it. But men have a long tube called the outlet and a bladder, which is a pump. as we sit here right now, we need a quiet bladder. We need a bladder that just absolutely can sit there, and it's miraculous. It can get larger and fill up with coffee, pop, beverages, but it should stay perfectly quiet. The outlet is the urethra, the prostate, here's the bladder neck, and the external sphincter, interestingly, sits right across here, right across this part of the urethra. And you can see it sitting right here. This is the external sphincter, and that's the one you can tighten. This is the prostate sits here, and there's the bladder neck which sits there, and that's the one it's involuntary. It just stays closed until your bladder contracts. So one more time, there's a bladder neck valve and there's a membranous urethra or external sphincter that we sit right there. When you take the prostate, you get very close to the external sphincter. When you do radiation therapy or brachytherapy, the external sphincter is very close, and it can also be potentially injured in both of those procedures as well. Here's an actual cartoon of basically removing the prostate. When we take the prostate and the seminal vesicles because of a tumor in there, then as surgeons we have to do something. We need to put the bladder and the urethra back together, which we do over a catheter. I think I've got a cartoon here of lifting the prostate off, leaving a stump of urethra, and then there's the neck of the bladder that we're sewing back together with the urethra and the catheter that's going to run through there. But here, this muscles, that's all that's left. That's the pelvic floor. But the bladder neck has been, for the most part, taken away with the specimen, taken away with the prostatectomy. So before surgery, you have 2 valves, and after surgery, you have 1 valve. And most people, 1 valve is enough. But for some men, they need 2 valves, or they need a stronger valve because their external sphincter, this pelvic floor, isn't strong enough. So this is what I went through already, but will I leak after prostatectomy? Absolutely. For the first few weeks, leakage is very common after prostatectomy. 2 to 6 months, most of the time, it should be getting down to 1 pad per day. After 6 months, I tell men, look, you might have to wear a pad for just in case, but I start to get nervous as a surgeon after this, wondering, is he going to get better? Now, statistics show us that most men regain continence achieved. If you wait 12 months, 24 months, most guys are going to get better. But by 6 months, you get a pretty good idea of whether the guy's going to get better. But it's entirely reasonable to wait to the first year. And what happens if you go see your surgeon and you say, I'm still leaking? Most of them will say, wait. Many will say, let's talk about it after a year. Some surgeons are a bit old school. I'll admit, they pat you on the shoulder and say, there, you're cancer-free. And this is what I don't want to hear. I want to see you. If you're bothered by leakage, let me at least talk to you. And then in my opinion, if it's 6 months and you're not where you think you should be, or think what the surgeon told you is not happening, then I think it's totally reasonable to start down the pathway. And that's the case whether it's brachy, cryo, radiation, prostatectomy, robot, HIFU, it doesn't matter. It should be at a point that I want to see some major improvement happening by 6 months. So what's the chance of leaking after prostate surgery? In a way, it totally depends on what you ask the man. In actual fact, if we're not going to do it, but if we did a poll of who has a pad on in here, a number of men might have a pad on because it's a social setting and they just don't want to have an accident tonight. And I'm not going to ask everybody, but you're thinking, oh God, please don't ask. But that's okay, because you may say, look, I didn't leak tonight at the meeting, but I had it on and I felt better that I had it on. And really, my leakage doesn't bother me. Other guys, I see them literally, if they put a Kleenex in their underwear and there was a drop of urine on it once a month, it would drive them mental. And they're going to be seeing me and I'm going to say, look, my devices have problems. I'm going to push you away. But a lot of what we do comes down to bother. It depends what you ask. Surgeons, nobody leaks. Patients, more people leak. If you ask patients, they're obviously pretty honest. Look, I'm wearing a pad. I know I leak. I got a yellow stain on my underwear. I know I leak. And a surgeon, I've never had anybody leak. Well, yeah, but especially if you don't ask the patient. And then it depends how you ask. If you look at your charts and you say, nope, none of my patients have ever leaked, that's a lot different than when the man's sitting waiting 2 hours to see you in your office and he completes a questionnaire and he reports right back to you what makes him leak. So as surgeons, we probably don't want to ask the question, especially if you're not interested in this. You want to get the high five of the cancer-free. But many people, truthfully, with prostatectomy, which is great, are going to be cancer-free. And I tell men, if anybody in this room has had a prostatectomy with me, I say, look, 6 months after surgery, we're probably going to be sitting here with your PSA of 0. And so everything we talk about is going to be what's happening with your erections and what's happening with your control. Because long term, those are the things that are going to drive you crazy. Because in general, prostate cancer, thankfully, is a very slow and long disease. As I remember coming to my first meeting and meeting the Warriors, and I thought, wow, there's a group of hormone sensitive, or I think it's hormone refractory men, but it just shows the long course. So if you have 10, 15, 20 years after your prostatectomy of incontinence, that's a long time. I think it's totally reasonable to say, is there another way to manage this? What do I tell my patients? Well, everybody that has a prostatectomy with me has a sheet. It goes through the risks of prostatectomy that I put down, and then I will put on there, actually, what's the risk that you will have bothersome incontinence long term? It'll say 1 to 10%, because not every man that has it is bothered by it. But as a surgeon, absolutely. I was not put on this planet to do absolute perfect work. I'm going to try to do my best work, but there is sometimes that people will have leakage, and we might need to do something about it. What about this really sexy thing, the robot? Interesting. It's the most impressive marketing tool that has ever gone through surgery. There are pros and cons to it. Right now, we don't have data to suggest in good studies that it's better. At the same time, it's an incredibly sexy tool. In the United States, 90% of prostates are removed by the robot. In Canada, we have 11 robots in Canada. We're nowhere near that number of cases. I'm not going to be biased one way or the other. I'm just going to say, whoever removes your prostate, whatever they do best, let them do it that way. So if they are a great robot surgeon, let them do it. But I wouldn't recommend being my first robot. And I could say, look, we got this great thing, and I'm going to do a couple with Dr. Kozak, and it's going to go really well. At the same time, you'll say, how many have you done? 0. Do I think this is the answer to everything that was wrong with open prostatectomy? No. I think it isn't. I think it's neat. 5, 10 years from now, we'll know whether this very expensive tool is worth it. So what makes you more likely to leak? If you had bladder problems before surgery, then it's not going to be helped to remove your prostate, radiate your prostate, put seeds in your prostate. Unfortunately, the older you get at the time of surgery, or the older you get as the time that you have cryo or HIFU, the more likely that you may run into trouble. If you've had radiation to your pelvis and then you have a prostatectomy, those things really start to add up in terms of bad outcomes for incontinence. If you had a Roto-Rooter or TURP, they found prostate cancer and then you had a prostatectomy, that's another risk factor for having a worse outcome. If you were wet before surgery, removing your prostate will rarely help it. There were a couple of famous papers basically showing that your hospital better do a lot. And in Calgary here, we have Rocky View, we do 400 prostatectomies a year. And most surgeons need to be doing lots of these cases. And we're pretty good in Canada, we do lots of cases. And also we're pretty good at policing ourselves internally and saying, look, buddy, I don't think you should be doing any more. Give them to the robot guy or whatever. So I think you can be at least reassured that most of the time if somebody operates on you here in Canada, they're pretty darn good at it. I will say that. They do a lot of them, and their outcomes are going to be very comparable to most fancy places in the States where you can easily drop 20 to 30 grand. I'm not saying don't go there, because man, a marble fountain and red carpet at MD Anderson, it probably looks pretty awesome. You walk in, there's a grand piano and somebody's playing it right there. We don't have that at the Rocky View, but I think your prostate's going to be removed pretty similarly, I'll be honest. What about the other stuff? Radiation, brachy, and cryo? Well, cryotherapy plus radiation therapy, so if you start combining treatments, I think when I first came to town, I thought Dr. Donnelly didn't like me because he was sending me some patients with radiation and cryo combination that were having incontinence. And that is a really tough group of patients to help. And there may be some men in here that are suffering from the consequences of the combination of radiation and then post-radiation failure with cryotherapy. If we get into that situation with incontinence, it gets really difficult for us to figure out the best way to control it. And then if we move on with artificial sphincters, we often will get into trouble with erosion. And even though I do a lot of artificial sphincters, I'm very nervous about putting a sphincter in this population. And that's because when you do a lot of stuff in the pelvis, you affect the blood supply. And I need the urethral blood supply to be really good if I'm going to put a sphincter on there. What about brachytherapy alone? There's some studies suggesting that brachytherapy is great for not having incontinence. At the same time, it can be quite an irritating thing to put radioactive seeds into the prostate. So each one kind of has pros and cons. My own bias as a surgeon that treats incontinence is if you have trouble and you've had one of these, I get more nervous putting in a sphincter because there's radiated tissue in the pelvis. I get very nervous operating on radiation. Doesn't mean I won't do it. Whereas the man that's had the prostatectomy with no radiation has incontinence, the tissue responds much more normally as a surgeon. It wants to move where it wants to move. The blood supply is more normal. It's not like wood. And so I'm not making a case against them. I'm just telling you as a reconstructive surgeon, radiated tissue is tougher for me to deal with. So why do men leak? So let's take a closer look. There's 3 types of leakage that we're going to touch base on. I briefly want to mention this one because this is really important. It's called overflow incontinence. It's an overfull bladder with a bit of dripping. Pretty typical story is a man had a prostatectomy. He was doing okay. He was having leakage. And then he told his wife, "Hey, honey, I finally got this beat. I'm totally dry." And then a couple days later, he says to his wife, "I'm dripping urine. I can barely pee." What's going on? He's got a bladder neck contracture. He's got scar tissue that's formed, and his bladder's overfull, and he's dripping urine, but he can't get a stream going because he's developed scar tissue. And it happens usually pretty quickly after the catheter's removed in the 4 to 6 weeks. It can be a really stubborn problem. If anybody in here has had a bladder neck contracture, you know that it may take more than one dilatation. It may take cutting it, lasering, stretching it. It may even take teaching you how to self-dilate or stretch it yourself. We're going to come back to urgency incontinence. This is the jumpy, twitchy bladder. More common in women, but men do get it. Especially if you've had your prostatectomy and then you had a stroke or Parkinson's disease, and these things start to add up on each other. And then stress incontinence, that's a weak muscle. That's the classic one. Okay, so basically it's the overfull bladder and it's just running over the top. So you're losing a bit of urine all the time like an overflowing toilet. And it's because as surgeons, we put you back together right here, the bladder, neck, and the urethra. We put it back together. But Mother Nature comes in there and she says her job is to bring the edges of a scar together. That works great if you cut your arm because you bring the scar together. But if you cut a circle and Mother Nature says, well, I'm going to bring the edges of the scar together, she can give us a contraction. I always blame Mother Nature for surgical problems. She's always on call. She never answers her phone, but she's always involved. So it's like a beaver dam. So you got a full pond up here and a little bit's running over the top downstream. And what is it? Here, right there. So if you've ever come to cystoscopy and you said, hey, I was peeing great and now it's like a pinhole. Yeah, it is a pinhole. This should be wide open. It should be like that after the prostatectomy. And the scar tissue is starting to form in there, getting tight and tight. And that's what it is. And we'll see it at the time of cystoscopy when we're looking down at the area of the anastomosis. And so it's not just the Baverstock wants to make money, that's why he's meeting you in cysto. If you tell me you got a problem, I need to look with my scope because I need to sort out what's going on so that we can get to the bottom of it. Because usually what we got to do, and this happened today, I had a man that had a TURP, a rotor-rooter out in the prairies. We're the prairies, but even more prairies. Then he had another one here, and then I saw him. I did a green light laser ablation, and sure enough, last week he said, I'm getting narrow and tight. And this is exactly what I saw, and I put him on the list for my office partner tomorrow, because he's got to be opened up. We got to open it up, and then I've got to teach him. I got to teach him how to manage this. He may actually have to pass a catheter himself to keep it open. Sounds horrible, but it sure beats the alternative, which is you can't pee and you come into Rocky emergency and nobody can get a catheter, and that's a crisis. So as a surgeon, you got to be pretty clued in. If the guy's catheter's out and he says, you know, I'm having real trouble peeing, it could be a bladder neck scar.
Excuse me.
Yeah.
If you open off, is it just going to start over again?
Yeah. In general, this is what most of us will do as surgeons. The first time if it's drastic, maybe in cystoscopy, we'll even pass a wire and then start to stretch you up. That totally depends on how much you can take in cystoscopy and how comfortable it is, how much sensation you have. But yeah, we will literally try and tear open the scar. And you're right in that it can come back. At the same time, every time Mother Nature tries to heal, she will sometimes heal it open. We're hoping it scars in an open position, and it will some of the time. So I'll usually stretch you or cut the stricture once, and then recheck you at 3 months. If you say, Doc, I'm doing pretty good, it's not that bad, I might check you later on. But if you say, Doc, I was great, it was amazing, and now it's right back to trouble again, then that's when I will open you up, and then I will actually go to the point where I will actually teach the man how to pass a catheter in and out, so that during the healing phase, it can't close down, and because once in the morning and once at night, he'll actually pass a catheter. Sounds drastic, but it beats the alternative, which is basically every time you go down to Palm Springs, you're in the emergency of the Eisenhower because you've shut down your bladder neck contracture. It's not a common complication after prostatectomy. I give it about 5%, 7% in some series, but it's classic, and as a surgeon, you know what's going on, and you want to help.
I've got a question. Okay, I can go through 5 pads a day easily. 3 of them pretty heavy. I went in and say I had the rotor, and went with the smaller one, a larger one, and a larger one. Okay. Then, like I'm to the point now, I'm doing this for 5 years. And I'm really, when I come tonight, it's because there's supposed to be some changes. And I'm getting to the point where I'm scared to go in and see a surgeon because it happened 3 times and it hasn't gotten any better. And it's happened right from the very start. So
This bladder neck
I
contracture?
have bladder like that, like you wouldn't believe.
No, wait, so you're saying you've got bladder neck contracture?
I'm sorry?
You're saying that you've got that scar tissue?
I suspect I did because he went in 3 times.
And did you go to sleep, or did you do it in local cysto?
Did it local, I could watch it on the
You
screen.
passed a wire and then started passing bigger and bigger stretchers
Exactly.
3 times.
Yes, sir.
And every time it comes back?
Every time it's come back, it's still come back.
Now, when he does open you up, are you better in terms of, is your stream better? Are you more wet? Are you less wet initially? Does it make any difference?
I don't think it made any difference. Some days I can go through maybe 4 pads. The other days I'll go between 3 and 6. 3 of them are really, really heavy.
Yeah, and when's the last time anybody looked to check your bladder neck? To see if you're scarred back up again?
I'm guessing 3-4 years ago.
And so, now, here's the situation, though, in my mind, this is what I'm thinking. If your bladder neck is okay, it stayed open in a reasonably okay fashion. Sure, I may not be able to get the largest catheter into you. I may not even be able to get my flexible scope into you. But you tell me your stream is okay, but I'm soaking wet here, Doc. What are we going to do about it? 5-6 pads a day, there's no reason you shouldn't have an artificial sphincter. I mean, no question. 5 or 6 pads a day, that's a lot. It's expensive, it's messy, and it's gone on for years and years. Now, but like I said earlier, why does Baverstock meet you in cysto? It's because if, let's say Dr. Metcalf, he says, you better come see Baverstock, right? Or you ask your urologist, I want to go see that guy. I'm going to meet you in cysto because I want to see if your bladder neck is still like that. I'm going to get it open, and then I'm going to teach you how to keep it open. And then once we've got it open, and how do we get it open? So I open it up, and then I get you to catheterize once a day for a month, then Monday, Wednesday, Friday for a month. And if you tell me, Doc, that's so easy, then I get you to do it once per week. And if we finally tell Mother Nature that's it, you can't close down, then we can move with then we'll usually move with the sphincter.
I was using that catheter, he said there's also a little pocket of urine that's in there. And I said, after you finish urinating, take the catheter, push it through, and it'll drain out. I do that at least twice a day. I did that too.
But if you were able to get it in, that usually is a pretty good sign that your bladder neck is going to stay open. But if it didn't make much difference to your incontinence, then emptying that last bit of urine doesn't make any difference, and it's time to consider something else. But if you consider something else, number one, we got to make sure that bladder neck's okay. And why is that? Well, because if I go putting $6,000, look at that, $6,000 worth of artificial device around your urethra with a little pump in your scrotum, and then you show up in emergency and you can't pee because the scar tissue is closed down, now we got to get the camera, the scopes, and everything through our artificial device, which we risk undoing good work here for your bladder neck. So I want your bladder neck to be okay, and then we would consider. But tough problem, right? Mother Nature, she keeps trying to close it down. But I'm pretty optimistic that because you were self-catheterizing, that it might be open enough that I would say, let's leave that alone and let's move on to that. Definitely at that much. 5 or 6 pads per day, that's a ton. I think there's lots of good options for that. Urgency incontinence. Now this is one that, any women in the room are going to say, that sounds oddly familiar. This is 3 million Canadian, about 8 to 12% of the population are estimated to have this, which is a bladder that's twitchy, jumpy. So you're pushing your cart through safely and boom, you got to go right now. And you can't even check the price on the chicken stock. You got to run for the toilet because the bladder has decided to contract. Remember I said my bladder neck is closed as we sit here? But if your bladder contracts, it turns on the involuntary opening of your bladder neck. And whoosh, before you know it, you've let yourself go. So that's a horrible situation because Mother Nature is waiting for you to stand over the toilet as a man and say, okay, relax your sphincter, contract your bladder, and your bladder neck opens. It's all open sesame. It all happens without us thinking. But if your bladder contracts for some reason, multiple sclerosis, you've had a stroke, maybe way too much coffee, you got a job interview, something makes your bladder twitchy, Mother Nature says, oh, bladder contracts, I'll open the bladder neck and out comes the urine. It's a horrible situation. And is it a big problem? It's absolutely, it's huge. It's huge in women, it's huge in men, and the problem with it in this situation is, once again, you've only got one valve. You can't even hold back with your external sphincter because your external sphincter may be weakened, your bladder neck is sitting open because you've had your prostate out. So if it was a problem before surgery, it could really rear its head after surgery. And also, if you remember, in your radiation field, Jackson Wu and Dr. Skarsgård and Dr. Angelfi, they want to target the prostate and the zone around the prostate. Well, that can get the bladder base. So if you already have a twitchy, jumpy bladder, and you put that AUA symptom score and you were like a 21, which is really high, meaning you're really suffering from your waterworks, and then you radiate the area, you could really get into some trouble where you got a lot of frequency, you got a lot of urgency, you're getting up tons at night, and you're even to the point where you can't even make it. So you're that horrible guy to bring on the road trip to Edmonton because we're stopping at Balzac and Airdrie, and that there was supposed to be a gas station north up there, but they closed that one down, and you're totally messed up in the car. So you always got to check with your buddies. You should do an overactive bladder symptom score before you get in the car with your buddies. And why is that? It's because your bladder contracts at the wrong time. It shouldn't be like that. But again, if after surgery you had 2 valves and now you're down to 1 valve, and so that can really become a problem. Stroke, neurological disease, Parkinson's disease, those things can add on radiation therapy. If you had a big prostate, and a lot of men, they had a big prostate, their PSA was up, but they were treated for prostate enlargement, lo and behold they had prostate cancer as well, and they may have had a really twitchy, jumpy bladder and a lot of prostate symptoms. A bladder infection, many women will report that, hey, when I had a bladder infection, I went pee way too many times. And so if you have chronic infections plus radiation plus, you're going to get a lot of overactive bladder. Coffee, there's probably some room for all of us to cut back on a bit of coffee if we like coffee. That's maybe a bit too much. Cigarette smoking. Every time I see you, I'm going to ask you if you smoke, and I always want to know because it can increase the risk of bladder cancer. This is obviously a prostate cancer meeting, but bladder cancer is so important in what I do as a urologist, and smoking is dangerous. And as I tell a lot of people, It seems like there's a growing body of evidence that putting things in your mouth, lighting them on fire, and inhaling may be bad for you. And bladder cancer is definitely one of those things. And then flooding yourself. Everybody says drinking water is good for you, but you know, you can drink too much, right? You know, there's this, people who say I'm flushing toxins, and I'll say, yeah, but Health Canada took away water bottles that had bisphenol A, so are you really flushing toxins? And constipation and headaches and promoting long life. But I always think, you know, I haven't seen that many parrots which live 80 years walking around with a water bottle, and they seem to be doing just fine. So there you are, you're trying to get your control back after your prostate surgery, and your wife's saying you got to drink more water, and the more you put in, the more that's coming out. And so there can be too much water, too much caffeine, and definitely if you pee too much already, you're going to pee too much after. Now there's a group of medications, which we're going to come to, that are designed to quiet down the urge, quiet down the frequency, and hopefully help with the incontinence, the urgency, frequency, and then urgency, oh my God, I got to go right now. And you can have both of these. You can have stress incontinence, you can have overactive bladder. Now there's lots of medications. Oxybutynin or ditropan is the generic. And in over 65 in this province, we're supposed to start with that. And then we can cut down to Detrol and Vesicare. These are my two favorite medications. I usually like to move right to them right away because they're one pill once per day. What's the problem with them? They all can have dry mouth, constipation. A blurred vision, I don't mean like, whoa, where am I? I mean like you're looking at something, you turn suddenly, and it takes a second to accommodate or get it into focus, and then you're okay. And that's what these drugs can do. And if you're 85 and you go on some of these medications, they can actually play with the brain centrally. Not that many people, but I always tell people, look, if grandma goes up to clean the chimney, and that's not her normal job, it could be the pill I started her on. She's getting ready for Santa. Now, even some of you in this room, I'm not sure, may have heard about Botox. Botox has been a miracle. Cosmetically, sure. The Hollywood stars, their faces are so tight and perfect. But I mean like useful stuff, like really useful stuff. And Botox, it's second line, it's down the road. The typical patient that I'll do Botox on is a lady with multiple sclerosis. She doesn't drain her bladder well, so she actually catheterizes herself, which she has to catheterize herself. We've already talked about using it in men, but some women don't empty their bladder with multiple sclerosis. But yet they can't go pick up their kids from school because they get such a sudden, overwhelming urge, and they have to go, or they have to wear a pad. And the pills don't work, and then we'll get to the point where I'll actually inject Botox into the bladder. It takes a few minutes. I can do it through a telescope, a cystoscope, right into the bladder wall. It takes a few minutes. I can do it under local anesthetic in ladies, or sometimes some sedation or general anesthetic. I've got some coverage at Rocky View, which is really unique. Within 1 to 3 weeks, people will say, I don't know what you did, doctor, but it changed my life. It's a miracle, fabulous, amazing. When would I use it in a man? Well, let's say there's a man that he has horrible urgency, frequency, he can't make it to the toilet on time, and he's tried the pills and they just didn't work for him, or the side effects were too bothersome. I may get to the point that I introduce this to you. This is not standard for coughing, sneezing, leakage. This is urgency, frequency, gotta go stuff. So now we're going to get out to the main one, which is stress incontinence. So, by far the most common type of leakage after prostate removal. It's usually related to weak muscles. And I don't mean that like, you know, you're weak, your buddy's not leaking, so he's not. I mean that as in, everybody's made differently. And I, as a surgeon, I tell people all the time, look, I can do an operation, it feels like the first one I ever did, and the guy is great. I can do another one, I think I should film it and play it at the intermission and Hockey Night in Canada because I'm that good. And the guy comes back and his PSA is detectable, he can't get an erection, and he's incontinent. So I can't look at a guy and say, you're going to have a phenomenal outcome. And that's frustrating as a surgeon. Sure, younger age and less comorbidities and you're very fit, those things are good. But the guy that leaks after surgery, sometimes you're like, really? It went so well, or I totally expected it to be different. And then if the guy's not where he wants to be, I think it's entirely reasonable to offer treatments. There's great treatments for women with stress incontinence, and there's good treatments for men. So this is your classic. It's coughing, sneezing, running, jumping. Lifting, sudden. And I've got some guys that have very specific leakage. Just reaching into the golf hole to get their ball out. Just reaching into the bottom drawer of their office desk. Those situations. Other people just coughing, just sneezing. Just lifting the dog into the back of the truck. Whatever it is that suddenly causes an increase and you're not able to hold your muscles tight enough. Again, it comes down to the pelvic floor because the external sphincter is just not strong enough to hold back that urine loss. How do I sort it out? We talked about cystoscopy, but basically, I want to know, when does leakage occur? Like I was asking the man over there, does it occur all the time? Does it occur only with activity? Were you better after the bladder neck was opened? Did you get a sudden urge, an overwhelming urge? Did you have a previous TURP? Did you get bladder neck scarring? Did you have radiation as well? Did you have diabetes, neurologic disease, previous pelvic surgeries like a colostomy, those types of things? And what medications are you taking? It doesn't take me very long to get those answers, but I'm usually always focused in on finding out how much of a bother it is and what other things are going on. Not all leakage is the same to every man. Another man wears 5 pads per day. Our man over here, he said he wears 5 pads per day. He might not like a drop of urine, so he changes it at the first drop of urine, whereas another man maybe can't afford pads and he would wear that same pad for a long time. I'm not saying that in this situation. But I'll give you an example. I had a lady that had multiple sclerosis, and the multiple sclerosis also was affecting her brain in terms of her cognition, her thinking. She came in to me, she said, I am completely incontinent. She was sent to me by a gynecologist. I'm incontinent. I'm going through 20 pads per day, which is expensive. And I was like, wow, that's as if you're not peeing at all. And her husband was waiting. I said, bring your husband in, because I'd like to meet him as well. So he says, Doc, I'm taking this garbage out, and these pads are not even wet at all. And so I said to her, I said, are you wet right now? And she said, yeah, I'm wet right now. And I said, well, your husband's here. Let's check your pad. And so I'm not proud. She pulled out the pad and she handed it to me. I said, is this wet? She said, yeah. And literally, like, the thing was like an air biscuit. It like floated up. I'm like bringing it down. It kept floating up. I'm like, this isn't wet at all. She said, no, that's wet. I would change that pad. So I turned on the tap and I put the pad under there and I counted to 20 seconds and the pad held it all. And that was like a heavy, heavy pad. And I said, well, this is a heavy pad. And her husband said, yeah, I know. I've been trying to tell her that, but she just won't get it. But that was MS. So she was 20 pads per day, but really, she was maybe 1 pad, maybe none. And yet she just hated the feeling of anything on there. So again, somebody says I'm 5 pads per day. I'm only going to ask them, are they heavy pads? Do you just change them? Some people wear a diaper and they put a pad in front of it. So they're 1 diaper per day, but they're 1 diaper and 5 pads. That's a different situation. Then, and here we are, basically, that's just my slide saying not all pads are equal. But some people wear a pad, but they also wear the clamp. And so that's a different situation. How often during the day are you having an urgency episode? And how much does this impair you? All of us might think, being incontinent impairs me a lot. But hey, if you have a great system of dealing with it, and you definitely don't want to get into any of this nonsense that Baverstock's talking about, I'm not going to push you into it. I don't want to talk you into it, because if I talk you into surgery and then we're in trouble with it, with an eroded sphincter, then I've really done you a disservice, in my opinion. So this is basically, not all pads are the same. Well, let's go back to that. And there's right from guards to pull-ups, and for some men, they get away with this stuff. Other men, they actually just find wearing this is a lot easier. It's just a lot cleaner. It wears just like an underwear and nobody can tell, whereas they don't want to fiddle around with pads. So not all pads are the same to each person. If I meet you, again, I'm looking for that scar tissue. Also, I'm looking to see, do you have any external sphincter function? Because if we're going to do that male sling, I need you to have some function. And then I'm probably going to do this urodynamics testing. I'm going to fill your bladder, hook you up to a computer, because I'm really looking, does your bladder have function? And does your and like, does your bladder muscle still work? How much can you hold and what causes you to leak? And I did an advanced male sling on a man. He actually was one of the rare guys that leaked after a TERP. And I did an advanced male sling, and he didn't pee for weeks. It even got into months. And it wasn't prostate cancer. And when I looked back at his urodynamics, his bladder muscle was actually quite weak beforehand. And so he was having a hard time overcoming the sphincter. So on a Friday, I said, that's it, I've had enough of this. I'm going to bring you in. I'm actually going to cut the sling, and I'm going to get you back to the way you were. Because he was in the office all the time. He was seeing my nurse. He was calling Courtney. He was seeing me. His wife was coming in. And so I got him a bed on a Friday. I said, look, I'm on call Monday. I'm going to come in. I'm going to cut it. He said, well, what should I do? I said, I don't know. Pray. Whatever you like this weekend. You're just going to sit around. I said, pray. So he came in and he prayed all weekend. And I came in on Monday. I said, I'm putting you on the list. I'm going to cut your tape. He said, no, I started to pee this weekend. Look at my numbers. Look at my residuals. I was like, okay, do you want to go home? So he went home. I didn't cut his tape, and he's still doing well. So I'll employ anything. Prayer, it doesn't matter. Anything to help the situation get better. This is actually urodynamics. Many of you may have actually been into this chamber. Basically, that's a chair you sit on. That's something you actually pee through. And this is the computer we hook you up to with the machine here, running fluids in, balloons. It's definitely somewhere where you check your pride at the door. You got to check your pride at the door, because this is weird. We're trying to recreate what happens in the real world, but that's not quite the real world that most of you live in. It's a pretty real world for me, but I really need to get to the bottom of it. So if you hear that Baverstock wants to do a cystoscopy in urodynamics, it's because I want to sort out what's going on. Pelvic floor exercises, it's always a great way to start, but it's really for very motivated people. It's for early on, and it's for people that are willing, one, to pay money, and two, to do the work, because it's hard work to do pelvic floor exercises. And I think the payoff can be huge, but you got to be willing to do the work. And I always think, there's Oprah Winfrey, the most rich lady, and she can't keep the weight off. So what hope do any of us have? She's got a cook, a personal trainer. She's got somebody that can do absolutely everything, and yet she has trouble keeping the weight off. So how are the rest of us going to make out with pelvic floor exercises? In truth, some people do really well, some people don't. I always talk about the dribble stop. I always print out Henry's pages there and give them to people, and he gets a lot of phone calls. Even though I do sphincters, I think there is a place for this. If the guy has very specific situations that he wants to be dry in, absolutely wear that. Some men find it comfortable, some men don't find it comfortable. Maybe they just don't know how to wear it properly. But I always put in a plug for that, because I think there's definitely a role for this. Surgical devices, the invents, the advents, and the artificial sphincter. Kegels. That's the Kegel. It really was a or a strengthening exercise designed for ladies. It's basically learning how to squeeze your pelvic floor. The best analogy I had, and I often will tell my patients this, is somebody says they put a pencil right in front of their penis, and they said, without obviously putting the pencil in the penis, try and suck that pencil up and hold it in there for 5 seconds. So as you sit there, just imagine there's a pencil there, and you try and pull the pencil up your penis and hold it there for 5 or 10 seconds. And I tell men, do that when a car commercial comes on, do it, because that's on all the time. Now an iPhone commercial, an iPad commercial, do it when you sit down at dinner, do it at a red light, and initially do that stuff. Now, is it going to get better on its own anyway? I don't know. I think there's no harm, and definitely in feeling like you're doing something early on. Now, I've also taken a lot of pencils out of the penis and glue sticks and stuff, so don't get carried away. And it does stop leakage to put something like that in your penis, but it's no fun when you can't pee. And it's also embarrassing when you have to come in. So here we are. There's the dribble stop. This was another version I found way back on there. Maybe there's a patent war going on. This is the local one, definitely the one that I send people to. And some really good feedback, and people always enjoy speaking to Mr. Rennick and even meeting with him. And I think it's really neat that we have that here in Calgary. Surgery, I always say, oh my God, here comes the surgeon again. That's what got you into the trouble. because that's what's going to get you out of it. So the Invance, I mention it in case you come across it on the internet. It's pretty much gone away. I did it when I first came here. I was doing them in Toronto when I was a fellow there, but they're gone away. They've been replaced mostly by the Advanced male sling and then the artificial sphincter. So again, mild, and mild is, you know, 1 or 2 pads per day, and they're not that wet, but I'm quite bothered by them, or it's very specific. I only leak when I do certain things. But if you're soaking wet all the time, I'm usually going to say, look, I can change your life a lot better by using the artificial urinary sphincter. What's the goal, or sorry, what's the advantage of the Advanced male sling? It's right now. Basically, you come in a hospital, I'm going to place the sling. It takes me about 30 minutes to place it under spinal or general anesthetic. And you're going to leave the hospital the next day being dry. I want to get you to avoid heavy lifting for a couple of weeks after. So it's effective for mild to moderate. It's minimally invasive, outpatient, immediate continence, and normal voiding is maintained. But there's about 10% of guys that have trouble peeing after I put this in. There's no pumps and stuff, and it doesn't mean that I can't do a sphincter later if it didn't work. So it's here it is, and we were passing around the room. Basically, it's a hammock that I put underneath the urethra to basically support the urethra. So I make a small incision in each of the groins, and then I make a small incision underneath the scrotum. Now, guys that have had this, they have a numbness under the scrotum. They have a sensation as if something is lifting them up under there, and that lasts 3 to 6 months. Some guys will have trouble actually peeing. So here's the vision of it, is that it basically lifts the urethra back up to where it used to be. I think it really compresses the urethra and works much like a lady's sling does. These are the, as I call them, the barbecue skewers that I use to put them in. There's nothing. The sales rep for the company, he was here earlier, and I don't know how, but he continued to get on the airplane with these things. I'm a surgical sales rep. Oh, sure you are. And it's like, are you kidding me? You can't get on the airplane with that. Here's the mesh, and if you've had a chance to see it, it's basically polypropylene mesh, which is basically just like fishing line. And then it's got a tensioning suture that runs down the middle, and I'm going to position this under your urethra. Basically, I'm going to send you home with a couple days of an antibiotic, some anti-inflammatories, or a painkiller. Some men do have to catheterize for 1 to 2 weeks or until prayer kicks in. The recommendations from the company, basically nothing that makes you strain, where you're going to open up your legs and potentially loosen the tape. And I'm going to say 3 to 4 weeks. Specifically heavy lifting up to a month. And it's frustrating because you actually will often feel good. I want to really test this thing out, but you got to let these things heal in. They're basically a ladder, I imagine. Mother Nature's got to grab onto it and heal into position. Now this is the gold standard. I always tell people 2 great things came around in 1972, me and this. And then I'm just mostly just making that up. But it is the gold standard. It has been around since 1972. It's called the Brantley-Scott device. It's been modified a couple of times. Interestingly, recently they changed the pump manufacturing, and there's a problem with the filing of the paperwork with the FDA. So last Tuesday I was supposed to do 2, and I've had to move them to the end of June because the FDA has said we need your paperwork, and so the company is working. So I'm saying that because if anybody in this room is waiting for me to do an artificial sphincter, right now I'm in a holding pattern until I get the approval from Health Canada to continue doing them, even though they've been around since 1972. It's a paperwork glitch because I still believe in this device. A lot of people will say, Doc, it's great, but I sure wish it was tighter. It can't be tighter because it's squeezing natural tissue. That's your urethra. This balloon generates 61 centimeters of water pressure, which is not a lot of pressure, and it's just enough to squeeze the edge of the urethra together. It goes on the outside of the urethra, and this little pump, it goes in the scrotum. It's not visible. You can walk into the shower at hockey, nobody can tell, but it's in there. But basically you got to go to the toilet and give a little squeeze. That's the size of the pump, and there's just a squeeze and have a pee. And the cuff device, this is actually, there's a cuff right here, and when I put it in, it's just like a belt buckle that I put around the urethra. So basically, it's working there. It's sitting around the urethra. It's holding back the urine. You can cough, you can sneeze, you can laugh, you can jump. It's not perfect. You may still get a drip of urine out there, and I'll tell men you may have to have a pad in. But if you've gone from 6 pads per day that are wet to 1 pad for just in case, that's not so bad. It's pretty good. And then it's time to pee. Go and have a squeeze. Your bladder contracts just like normal. You feel like you've got to pee just like normal, and then the urine goes through, and then the pump automatically closes down within 1 to 2 minutes. There's what it's doing. There it is, closed. So still a little bit of urine can get by, and then there it is, open, so the man has pumped it. And so that's what it does. It puts pressure. But there's a problem with putting pressure on the urethra. To do this, you obviously got to have the use of your hands, because I'm not going to put it in if you say, yeah, my wife will do this. It's like, no, you've got to be able to do this. Because what if she wants to get away from you? Because I already want to. You got to understand that I'm putting something inside of you. I'm not going to put it in at the time of your prostatectomy because you may never need it. And then I think really the risks don't scare you off because you really want the benefits. So just a close-up, here's the pump, there's the cuff, and there's the balloon. Keeps the pressure in the system, moves through, and keeps that closed. Then when you pump, moves back through into there. These are the risks. Infection, erosion. What is erosion? Erosion is where it rubs itself into the urinary passageway. It's a particular disaster. You've got this in, you got your life back, and then boom, you have a heart attack, and your family rushes you into the Foothills Hospital. They're so worried about your heart, they put in a catheter. Don't ask anybody about any of this. 3 days later, you wake up and your family says, oh my God, you're alive. And then the first thing you says is, oh my God, my sphincter. And that's because you got to remember, there is a rim of natural urinary passage tube, the urethra. And then if you put a catheter down, it's like rubbing 2 sticks together on Survivor. You're going to get a fire, and the fire is going to be this thing eroding in. And all the good stuff we did, I'm going to get a phone call saying, oh, and I'm going to take it out. And then we're back to square one until we can get you better. Revisions, it's mechanical. I tell people there's a 5 to 10% chance that over the next 10 years or so you're going to find me and we'll have to change something. And but most people, they know it. They lean over the hood of their car, they're changing their oil, and boom, something happened. And usually there's just a little leak right there, or a tubing connector. It's usually not the pump, actually. The pump is usually fantastic, or the belt buckle on the cuff has come undone. Rare stuff, but it happens. How good are people? Most people would say, I would recommend it to a friend. It's funny, I surveyed my own people. There was one guy that everybody said, 91% of people said that they would have it done again. 93% said they would recommend it to a friend. So there's one guy that wouldn't have it done again, but he would tell his friend to have it. He didn't like his friend, I guess. But in general, most people say it really is a great device. And I feel very strongly about it, as long as you understand that we may be monkeying around with this thing, infection, erosion. And if you've been down this pathway and you've had a working device and then it stops working, you sure want me to jump on this and fix it, because you want to get back to having had a great chance at being pad-free. This is great. So if your urologist doesn't do it, and pretty much in town now, most people other than Dr. Carlson and I have given it up, and I'm very passionate about this device. I really think this can change people's lives, but it's got risks. And tell them that you saw it and you want one of those. So final slide here, and then we can get out in the cool night air. Post-radical prostatectomy can be stubborn. It can be a long time course. There's a lot of things. It really affects people's quality of life. I think living with pads can be really frustrating. I think there's answers, but I gotta sort out what's the cause of your leakage and how I'm gonna make you better. And then often it usually ends up being surgery to make you really better. A sling, Botox, an artificial sphincter. And my preference is to go to the sphincter, unless it's mild amount of leakage, then I'll talk about the male sling. So we'll do questions. Questions? Or you can run out of here if you got to get home and let the dog out for pee, whatever you want to do.
Never mind the dog.
Never mind the dog. Exactly. Anybody questions?
My dad was 86 wearing diapers at night.
Yeah, so you guys may not have heard. So his dad's 86, just diagnosed with prostate cancer on hormone therapy. And truthfully, that's probably going to control the disease very well for quite a long time. But he's got urgency incontinence, so I mentioned about the mentation. I'll tell you my original thought. So he's 86. I'm not sure why he necessarily had a PSA, but maybe he had voiding symptoms. Maybe he was having trouble with the waterworks.
Yeah, he had trouble with the waterworks.
Yeah. So in a way, I'm not going to say it's accidental that prostate cancer was discovered, but it's a piece of the puzzle. My first thought is, I wonder if he's emptying his bladder. He needs a flow-in scan to prove if he's emptying his bladder. Then he needs somebody to check him and say, dude, let's improve the way you pass your water. In actual fact, he'd probably benefit from a TURP or a green light laser, because he may not be emptying very well. Because he's at 86, he's going to have prostate cancer, and we know about that, but he's probably got a large component of prostate obstruction being 86. So my first thought is, actually, the hormones may help, but it's got to give it time, 3 to 6 months for the hormones to do a job. He may benefit from Flomax. We got to make sure that he's emptying his bladder with a flow-in scan, come in and check that he's emptying. And then he actually may do great with a TURP, a Roto-Rooter, not for his prostate cancer, but to improve his emptying. So that's what I'd be thinking before I'd be thinking about the anticholinergics. A TURP.
Yeah, I think he's been on Flomax for about 18 months.
So Flomax should work within 5 to 7 days. So you said Scottsdale or Scotland? Scotland. Okay, well, we can't see him, but they got good.
I'm going to visit them, so I thought I'd find out.
So, is he emptying his bladder? If he's emptying his bladder and it's just overactive bladder, gentle trial of those medications I talked about, being mindful that they can affect the brain. And then if he isn't emptying his bladder very well, then he may benefit from something beyond Flomax. And it sometimes will come to surgery.
I have a question. How long should a person take it, and is there any side effects?
Okay, so if you're taking it for prostate enlargement,
That's what you
so
diagnosed me.
okay, so taking it for prostate enlargement, if we want to see the PSA fall, it'll take 6 months. If we want to see it work for the prostate symptoms, we know that by 12 to 15 months, what we see is what we get. So if at 15 months you say, Doc, I'm no better than I was, then from a voiding point of view, it's probably not going to help. It's probably not going to help you pee better. But I can't remember off the top of my head. I might be using it to keep your PSA down.
Yes, you did.
And it responded.
Cut it half.
Cut it in half, exactly what it should do. And then we want to see it stay down pretty smooth, because if it stays down pretty smooth and doesn't rise, that's usually a suggestion that it's prostate enlargement, not prostate cancer. So it's a little bit of a test on that one.
Right.
But if it's working, I'll usually keep you on it long term.
Okay.
And watching for side effects, though.
So far.
Bob?
Could you talk a little bit about the urgency at night when you have to get up in the middle of the night?
Okay.
I'm 14 years now post-brachytherapy. Never had a problem with incontinence. But every once in a while, 1:30 to 2 o'clock in the morning, I gotta get up and go.
And is there good pee there? Like, do you have a good strong stream, or you're like, bah, that's it?
That's it. Yeah.
Okay. So, one time we could have a talk about nocturia, nature's nighttime call, nighttime peeing. There were so many reasons for nighttime peeing. Right off from tonight, Bob, you and I decided to go have some beers after. We don't normally do that ever, but we do it. And then I'm cursing you because I'm tired of my clinic tomorrow because I was up peeing. So alcohol, sleep disturbance, lots of stuff on my mind. You going to see the doctor tomorrow, I wonder if my PSA will be up. Oh, I'm waking up. So sleep disturbances. Getting older, unfortunately aging, we get a reversal of our day and night pattern. So you go back to getting up at night. Then congestive heart failure. You take off your socks and you can read Reebok in the side of your shins. When you lie down at night, that fluid goes back into your vascular system. Your heart says, where's all this fluid coming from? It sends a message to your kidney to bail water, and you get up to pee. So that happens. So if a lot of guys in this room will be on a water pill, but they take it in the morning. But then they get rid of their fluid in the morning, then the rest of the day they're okay, but then it reaccumulates at night. It can be part of overactive bladder, but then I would almost expect you to say, yeah, but and when I'm out in the meeting, an urgency frequency. So if it's just isolated nighttime pee and sometimes it comes and goes, it's usually something else. It's a sleep disturbance, something woke you up, that kind of thing. If it's happening every night and it's 3 or 4 times, or if it's happening, you wake up and it's a crisis and you're wetting yourself, then it's usually overactive bladder. But it is probably one of the most complicated things for me to sort out, and also one of the most difficult things to actually treat, to the point where I'll even send people for a sleep study to say, I did that today, help me figure out why this guy can't stay asleep. So,
you mentioned green light laser at the beginning of your presentation. What is it?
So the green light laser is basically a newer, fancier way of doing a roto-rooter or TURP, transurethral resection. It's not specifically a prostate cancer treatment. It's just a treatment to open up prostate benign tissue. Green light, 532 nanometers. Its target molecule is hemoglobin, so it's virtually bloodless in surgery. Post-operatively, you can still have some bleeding like a TURP. But it's kind of a new, sexy way to deliver energy to the prostate to get you peeing better. And it's got some very useful roles. Yeah.
On the artificial sphincter, what does that do to sexual activity?
So in general, if it was bad before, it's not going to change. It's not going to improve your sexual function, except if you had no confidence going to the bedroom because you're soaking wet, and I make you dry, you may have confidence going to the bedroom and be able to work on some of the other stuff. But it shouldn't negatively impair or help the erections, because the urethra tube is separate from the 2 corporal bodies that are so important for the erections. But usually if a man's really struggling after prostatectomy with incontinence and erectile dysfunction, truthfully I usually say, let's get you dry, because then we can work on getting you with erections. Because unless you have a really understanding partner, going to the bedroom with a diaper on is, some people are into it, but not everybody.
Doesn't matter a bit.
There you go. See? But I'll usually say, let's work on getting you dry, but this device probably won't help you with the erections, but it shouldn't hurt them either. That was just a generic, that's just a statement? Sorry, I missed it. So if you have HIFU, can you have?
No, I said that if you have a HIFU procedure, then you will not have any issues with scar treatment. There wouldn't be any scars.
Scars with HIFU?
Yeah.
That wouldn't have been my first thought. One of the biggest frustrations we have is patients from here go out to Ontario, they drop $23,000 and then they return and they show up in our emergency department completely obstructed with basically a prostate that looks like wood, and we have to carve our way through it, and the patients are getting frustrated to us that we can't make them better. And we do see that. In general, everything we do to the prostate can have consequences, and HIFU is without exception, or HIFU is one of them that can cause trouble, just as cryo, just as brachy, just as radical P, robot, and HIFU. If somebody has a great response to HIFU, that's awesome. I'm happy for them. But what really frustrates us as surgeons is if they have a bad experience with HIFU, it's as if the phone was taken off the hook back east. And yet the patient dropped $23,000, $25,000, and I can't get the attention of the person in Ontario. I think that's wrong. So that's it's high intensity focused ultrasound. And it's a great treatment for some guys. And I don't want to rain on anybody's parade here, but yeah, as a reconstructive surgeon, the guy with the obliterated prostate from HIFU is a real tough case for me to sort out, because we got to really core it out to get back to tissue and make sure it doesn't close down, especially if you combine HIFU and other therapies. But some guys will have a great response to HIFU, and that's awesome. And some people will have a great response to brachy, and even radical P. Some people breeze through, other guys don't. So that's my take on it. But I have a take on everything. So, any other questions, guys? Oh.
Yes, I'm
22 years ago, and I have been told my prostate's enlarged quite a bit, and I have to go to the john about 12 times a day, and 50% of the nights I'm up once. And my stream on a scale of 0 to 10 would be about a 5. The question is, would that green laser do me any good?
Well, I mean, I hear all day, all I do is listen to people tell me how they pee. So my brain was like 88, he gets up once per night. What's his secret? I'm trying to get my 15-month-old to stay asleep, and I'm up 2 times per night. So I'm like, I'm coming to your house because it sounds pretty peaceful. So I wouldn't want to monkey around with that. When it comes to 10 times per day, 8 is considered normal. I think we could do better. The problem is we could do worse. We got to balance being 88, and you might be the best 88. In fact, your dad's here and you guys are going up Everest tomorrow. That's great. But I got to remember that we could make you worse. But absolutely, it's something that we could consider. But your stream is 5 out of 10. Do we do all that and make you a 7? And you pee 8 times per day? Is that a good outcome? And so it would definitely be something that you and your urologist would discuss and say, is that for me? And it's going to be ultimately your choice, because it's going to come down to bother and quality of life.
One other symptom I didn't mention is I have almost once a day some period where I have urge problem. I have to go, I can't wait.
Yeah. And I think, remember, obstruction can be an important part of urgency. And so you might do great with medication. You might not, because you've had the Roto-Rooter, as you said, years ago. So you might do great with a green light laser. At the same time, you might do great with Detrol or Vesicare. And I didn't mean that older people shouldn't take the medications. I just mean that every medication we got to be cautious with thinking about the risks. So I didn't give you a straightforward answer. You might be great, but at the same time, it's going to be risks and benefits.
One last question, and then we'll call it quits.
The recovery time, in regard to the advanced sling or the artificial sphincter, what's the difference? How much longer is the artificial sphincter recovery time? So we're back to what we might call normal.
Yeah. So the problem with the artificial sphincter, if there's a problem, is you come and you have surgery. The next day you're like, doc, what are you going to do? I don't turn it on for 6 weeks. Then you come to the office and I squeeze the pump and actually start to cycle it. So for 6 weeks, you're just as wet as when you came in, and you're sore. But usually with the artificial sphincter, you can go back to how you were kind of at 3 and 4 weeks, where you'll be like, I'm a little bit sore and I can't wait to get this turned on. By 6 weeks, we turn it on, you're usually good for everything. The advance, probably a quicker recovery. There's the pressure underneath. But then I'm keeping you back. I want you to avoid doing heavy lifting and straining for into 4 to 6 weeks. So in the end, when the dust settles, they're very similar, but they're in terms of 4 to 6 weeks. But I think you'd feel like doing stuff a lot sooner with the advance, but I'm holding you back because I don't want you doing too much. And the artificial sphincter, you might feel like doing stuff sooner, but I haven't even turned it on, so you don't get the benefit of being dry yet. So I'm going to tell you 4 to 6 weeks, and you're going to be pretty similar in terms of just don't plan anything wonderful till after that.
I think the dribble stop is the only answer.
Here he is. And I think there is a spot for the dribble stop in my practice for sure. But I think there's lots of answers.
Doctor, I keep thinking that Henry has to take that on Dragon's Den.
Yeah, Henry. Brett.
I'd love to see them talk about that.
I want to see them put it on Dragon's Den. I've sent you lots of people, right, my friend? You may not even ask who sent you up here.
All evening and I haven't gone to the washroom yet.
Okay. What's his secret? Hey, the dribble stop.
Thank you very much. Thank you very much, Dr. Baverstock. Excellent. I really enjoyed that. I can't turn this on so you can
Okay. Thank you guys very much for having me. I always enjoy coming out.